class is about the restorative materials used in pediatric dentistry. The restorative materials are the synthetic components that can be used to repair or replace the tooth structure. The ideal requirements of the restorative materials should be biocompatible, should restore the aesthetics and maintain the physical strength of the crown. It should preserve the occlusal anatomy and intercuspal relationship and prevent the micro leakage. It should bond permanently to the tooth structure, and also it should be capable of initiating tissue repair and regeneration. The materials which can be used as a basis are the zinc oxide eugenol, calcium hydroxide, zinc phosphate cement and glass Hynoma. The selection criteria for the restoration, it should depends upon the age of the child, the high risk or the low risk caries patients, type of the tooth to be restored, size and shape of the cavity, nature of the child. Silver amalgam. Dentists have used it for restoring the teeth for more than 150 years. The dental amalgam is produced by mixing liquid mercury with solid particles of an alloy of silver, tin, copper and sometimes with zinc, palladium, indium and selenium. This combination of solid metals, it is known as the amalgam alloy. The classification, it is based upon the copper content. It can be classified as high copper content with more than 12% of copper and low copper content with less than 6% of copper. Based on zinc, it is classified as zinc containing alloy and zinc free alloy. Zinc containing alloy has more than 0.01% of zinc and zinc free alloy has less than 0.01% of zinc. Based on particle shape and type, it can be classified as lathe cut and spherical particle. The lathe cut, it is the irregularly shaped fillings which is produced by cutting an ingot of alloy on the lathe. But the spherical particle, it is produced by atomization of the alloy. The physical properties, the compressive strength of the amalgam is high because it has an advantage. It will reduce the possibility of fracture by prematurely high contact stresses from the patient before the final strength is reached. The tensile strength, it depends upon the cavity designs because it should reduce the tensile stresses which results from the biting forces. The transverse strength are sometimes referred to as the modulus of rupture. The amalgams are brittle materials, so they can withstand the little deformation during the transverse strength testing. The elastic modulus, due to the high copper content, the amalgam will tend to be stiffer than the low copper alloys. Creep. Higher the creep magnitude, the greater the degree of marginal deterioration. Corrosion is the progressive destruction of a metal by chemical or electrochemical reaction with its environment. Thus, the excessive corrosion may lead to increased porosity or reduced marginal integrity or loss of strength, and also release of metallic products into the oral environment. Thus, the presence of high percentage of tin in the silver amalgam will reduce the corrosion resistance. And the recommended mercury alloy ratio should be 1:1. Indications, it is indicated in moderate to large restorations that are not in highly aesthetic areas of the mouth, restorations that have heavy occlusal contact, restorations that cannot be well isolated, restoration that extend onto the root surface. It can be used as a foundations or abutment teeth for the removable partial denture, temporary or caries control restorations. In contraindications of amalgam includes aesthetically prominent areas in the posterior region, small to moderate class 1 and class 2 restorations that can be well isolated, and small class 6 restorations. Advantages of amalgam includes it is easy to use, it has high tensile strength, excellent wear resistance, has favorable long-term clinical research results, and it is lower cost when compared to that of the composite restoration. Disadvantages includes it is non-insulating, non-aesthetic, less conservative, it will weaken the tooth structure. and more technique sensitive and more difficult in tooth preparation, and also it will have an initial marginal leakage. So, mercury toxicity includes the amalgam tattoo, which is a common pitfall of the amalgam restoration. Thus, the maximum level of occupational exposure is considered to be 50 microgram of mercury per cubic meter of air per day. Bonded amalgam restorations. These bonded amalgam restoration have significant advantage over the both conventional amalgam restoration and posterior composite resin restorations. The cavity designs of the for the conventional amalgam restoration, it is retained by the mechanical retention like undercut cavity design, but this bonded amalgam restoration will have the incorporation technique, which reduces the need for the removal of the sound tooth structure. And for the handling properties, it has good aesthetics and ability to bond both to the enamel and the dentin by the acid etch technique. It has no polymerization contraction, and bonded amalgam restoration show significantly less marginal leakage when compared to that of the conventional amalgam restoration. And for the cuspal flexure, the use of bonded restoration in posterior teeth will show reduced cuspal flexure and also increase in the structural integrity of the tooth when compared to that of the conventional amalgam restoration. Then composites. Composite is defined as a complex tooth color filling material which is composed of synthetic polymers, particularly the ceramic reinforcing fillers, molecules which promote or modify the polymerization reaction that produces the cross-linked polymer matrix, which is from the dimethacrylate resin monomers and silane coupling agents, which will bond the reinforcing fillers to the polymer matrix. It was first developed by Bowen in the year 1963. So, the classification of the composites, which based on the filling particles, includes the macrofiller and the microfiller composites. Macrofiller as macrofiller composites and hybrid composites, and microfiller as homogenic microfiller and inhomogenic microfiller composites. Thus, for the macrofiller composites, the properties include the physical properties, radio opacity, polishability and wear resistance, and it can be used in core build-up material under the indirect restorations, but it is no longer indicated nowadays. And the hybrid composite, it has the properties of radio opacity, polishability, polymerization, shrinkage is present in this hybrid composite. It can be used in all types of restorations. Microfiller composites. For the homogenic microfiller composite, it has good polishability, wear resistance, water absorption, radio opacity and polymerization shrinkage. It is used in small anterior restoration and class 5 restorations. For the inhomogenic microfiller composite, it has polishability, it has good aesthetics when compared to other three composites and physical properties, and it can also used in small anterior restoration and class 5 restorations. The factors which influencing the polymerization process are the first is the curing time. It depends upon the resin shade, light intensity, depth of the cavity, thickness of the resins, curing through tooth structure and the composite filling. The shade of the resin, which includes the darker composite, will cure more slowly and less deeply when compared to that of the lighter shades. The composite at the room temperature cure more completely and rapidly. And thickness of the resin, it should be about 1 to 2 mm is considered to be the optimum thickness. Types of fillers it can should be used is microfine composites will more difficult to cure than compared to that of the heavily loaded composites. So the distance between the light and the resin, it should be less than 1 mm when the light position 90 degrees from the composite surface, and the wavelength for the source of light, it should be 400 to 500 nanometer, and the polymerization shrinkage, it depends upon the amount of the organic phase. Types of composite. First is the hybrid composite resin. It is these composites are so called because they are made up of polymer groups, that is the organic phase reinforced by an inorganic phase which comprising 60% or more of the total content. The properties of these materials are they are available in wide range of colors as less curing shrinkage, low water absorption, excellent polishing and texturing properties. It has abrasion and wear resistance which is similar to that of the tooth structure, and thermal expansion of coefficient is similar to that of the tooth, and it can be used for both the anterior and the posterior tooth. Flowable composite, these are the low viscosity composite resins which make them more fluid than the conventional composite resins. The advantages includes high wettability of the tooth structure, ensuring penetrating into every irregularity of the tooth structure, and the ability to form the layers of minimum thickness, thus improve or eliminate the air inclusion or entrapment within the restorations. It has more radio opaqueness and available in different colors. The drawbacks include it has high curing shrinkage due to the lower filler load and have weaker mechanical properties. They are indicated in class 5 restorations, cervical wear processes, and can be used in liner materials in class 1 or class 2 cavities, and also used in cavitated enamel. Condensable composites, they are the composite resins with a high percentage of filler. The advantages are condensability. It has condensability which is similar to that of the silver amalgam, and greater ease in achieving a good contact point, better reproduction of the occlusal anatomy. The disadvantages is difficult in adaptation between one composite layer to the another, and difficult in handling and poor aesthetics in the anterior teeth. It is indicated in class 2 cavity because it will have a better contact point. Compomer, the word compomer which composed of composite and glass ionomer components. This compomer is developed in an attempt to take advantage of the desirable qualities of both the materials, that is the composite and the glass ionomer cement. So it will provide the good aesthetics, and it can be used in deciduous dentition in the low abrasion resistant areas. It has good fluoride release during first 24 hours of the setting. After that, it has an ability to recharge with the fluoride from the environment. Thus, it results in longer lasting caries prevention. Silyene, the name refers to its chemical composition from siloxane and oxyrens. This product aims to have lower shrinkage, longer resistance to fading, less marginal leakage. Geoma, it is the recently introduced hybrid aesthetic restorative material which is based on the pre-reacted glass ionomer technology. Chemically, it is composed of fluoroaminosilicate glass reacted with the polyalkanoic acid in water prior to inclusion into the silica, which is filled with urethane resin. It is indicated in root caries, cervical caries, class 5 cavities, primary tooth. And the advantages includes it has continuous fluoride release from the material, it has good clinical stability, it is biocompactable to the tissues, it has good aesthetics and ease of bonding. So indications for composites is class for all type of cavity preparations, foundations, or can be used in core buildup. It can be used as a sealant it can be used in preventive resin restoration technique, and also it can be used in aesthetic procedures like partial venice, full venice, to contour modifications, and also in the closure of the diastema. It can be used as a temporary restoration and also in the periodontal splinting. Contraindication includes if the operating site cannot be isolated from contamination by the oral fluids, and if all the occlusal load will be on the restorative material, it should not be used because it cannot withstand the fracture resistance. And in economics, restorations that extend onto the root surface may result in less than ideal marginal integrity. Advantages: composites is always have a good aesthetic when compared to other materials, conservative of the tooth structure removal, tooth preparation is simple, have low thermal conductivity, used in all types of tooth preparations, bonded to tooth structure, and it is repairable. Disadvantages includes may have a gap formation, time consuming, costly, establishing proximal contacts, axial contacts, embrasures may be more difficult. So it is technique sensitive and it will have marginal leakage due to polymerization shrinkage. Lime calcium hydroxide. It was first introduced in dentistry by Ehrman in the year 1936. It is the white color odorless powder and with a molecular weight of 74.08. It is low solubility in water which decreases as the temperature rises. Thus, it will have a high pH with a range of about 12.5 to 12.8. It is insoluble in alcohol. Thus, due to its low solubility, it has a good clinical characteristics. Because of a longer period, it requires to soluble in tissue fluids when calcium hydroxide is placed directly with the tissues. The mechanism of actions on hydroxyl ion bacteria. The calcium hydroxide, due to its high pH, it will have an intense transfer of available nutrients through the membrane. So it will have inhibition and toxic effect on the cell, which causes lipidic peroxidation and lysis of the cell. On the tissues, it will activate the alkaline phosphatase from the tissues. Thus, the phosphate ions get released from the tissues. When this phosphate ions reacts with the calcium ion from the bloodstream, it will form a calcium phosphate. This in turn forms the hydroxyapatite crystals. But this calcium hydroxide on direct contact with the tissues, it will have zone of necrosis in the adjacent tissues due to degeneration of the protein, which can occur within 7 to 10 days. The calcium hydroxide can be used as an intracanal medicament, endodontic sealer, pulp capping agent in the treatment of the apexification and pulpotomy, and also used in weeping canal. Weeping canal is nothing but when the blood discharge or the exudate reappears during the second appointment of the treatment. It is called as weeping canal. So the advantages include, initially the calcium hydroxide is bactericidal, then it becomes a bacteriostatic. After that, it will promote healing and repair of the adjacent tissues. Due to its high pH, it will stimulate the fibroblastic activity and also neutralizes the low pH of acids, and it will stop the internal resorption and inexpensive and easy to use. Disadvantages, it is associated with the primary tooth resorption, dissolve after 1 year with the cavo surface dissolution. It may degrade during acid etching, degrades upon tooth flexure and marginal failure with amalgam condensation. It will not adhere to dentin or resin restoration. Next is glass Hynoma Siemens. It was first introduced by A.D. Wilson and B.E. Kent in the year 1969. It has the properties with low solubility, fluoride release and fluoride recharge capacity, high compressive strength. It has a chemical bonding to the tooth structure, low flexural strength and low shear strength. It has a rough surface texture and it is biocompactable to the tissues. The types of GICs includes type 1 to type 9. Type 1 is used for luting, type 2 is for restorative, type 3 is for liners and bases, type 4 is for fissure sealant, type 5 orthodontic Siemens, type 6 code buildup, type 7 commensurate with the fluoride release capacity, type 8 is for atraumatic restorative treatment, type 9 for geriatric and pediatric patients. So the composition of glass ionomer includes liquid and the water. The liquid includes polyacid, that is acrylic, malic and itaconic acids. Water, co-monomer. Co-monomer is the D-tartaric acid. It will accelerate the set reaction, increases the working time, increases the translucency and the strength of the material. The recently added is the polyvinyl phosphoric acid. Powder includes alumina. It forms the skeletal structure of the glass ionomer cement. It has increased opacity. Silica, it has increased translucency. Calcium fluoride, it has increases opacity and also it acts as a flux. Aluminium phosphate, it has decreased melting temperature of the material and it will increases the translucency. Cryolite, It also acts as a flux. Fluoride, it will decreases the fusion of the material. It acts as an anti-corrosionic material and increases the translucency. The powder liquid ratio for the when GIC is used as a luting, the powder liquid ratio should be 1.5:1, and for the restoration it should be 3:1. So the setting reaction of the glass Hynoma cement, for when powder and liquid are mixed, the glass Hynoma will get attacked by the hydrogen ions of the polyacid, that is from the liquid. So when it is get attacked, it will release the calcium, aluminum, sodium and fluoride from the glass particles. This calcium and aluminum will replace the hydrogen groups of the liquid, that is the polyacid, and forms the calcium and aluminum polysols. These salts will get hydrate to form gel matrix, but the unreacted glass particles will be there. This will get surrounded by the silica gel that will arise from the loss of the surface cation. Thus the sodium will replaces the hydroxyl ion and forms the sodium fluoride. The fluoride will lie free within the matrix and it will able to conduct the fluoride release. The indications includes non-stress bearing areas, class 3 and class 5 restorations in adult patients, and class 1 and class 2 in deciduous dentitions. And also it is indicated in crown margin repair. Cement can be used as a cement base and coat built up when at least 3 walls of the tooth are remaining. And contraindication, high stress applications areas, class 4 and class 2 restorations, cusp replacement, core build up with less than 3 sound walls remaining. The advantages includes it bonds to the enamel and dentin. It has a fluoride release and it can be recharged. The coefficient of thermal expansion is similar to that of the tooth structure. It is a tooth colored material and it has low thermal conductivity. Disadvantages includes opacity, which is higher than the resin, poor wear resistance, it is brittle, poor tensile strength, poor longevity in xerostomic patients. The recent developments of glass Hynoma cement includes it has modified powder liquid system. The modified powder liquid system with improved wetting of the powder by liquid helps the mixing process much easier and faster. And capsule system which contains pre-measured glass Hynoma and powder and liquid. It has an angled nozzles which act as a syringe. It helps in accurate placement of the material into the cavity or crown for the cementation. Paste dispensing system. It is easy mixing, easy placement and easy to use the material dispenser. The modifications of glass Hynoma cement includes metal modified glass Hynoma cement. It is the silver alloy hot mix, that is the silver amalgam alloy particles which is mixed with glass particles. It has an improved strength. The Siemens gave the name as miracle mix for the metal modified glass Hynoma, which can be used in core buildup and also in patients with high caries risk incidence. But the disadvantage is it has poor aesthetics and it cannot be burnished. Cermet is the glass sintered with the silver, which was first developed by McLean and Gassa. It has more resistance to abrasion and high flexural strength, but the flexural strength is not equal to that of the amalgam alloys. Thus, it can be used only in low stress bearing areas. Resin modified glass Hynoma cement. It is the visible light cure glass Hynoma or hybrid glass Hynoma cements. It is developed to overcome the disadvantage of the conventional GIC. That is, the conventional GIC has moisture sensitivity and lack of command cure. Thus, along with GIC, with the addition of hydroxyethyl methacrylate at bis GMA in the liquid is added to overcome this disadvantage. It can be polymerized by light curing mechanism. High strength packable or high viscosity glass Hynomas. It is used in atraumatic restorative treatment. It can be used as an alternative to amalgam in posterior preventive restorations. Here the cement sets by conventional neutralization reaction. It has rapid setting and reduces the moisture sensitivity and it has low solubility. Thank you.